Hello, everyone. Good evening from Brazil. I hope you're having an amazing week, and I'm very glad to have all of you today on this very special webinar. So, just to introduce myself to you, my name is Letícia Campos. I'm a fourth year medical student from University of Pernambuco in the very northeast of Brazil, and I'm serving as the current General Secretary for InciSioN Brazil. That is an abbreviation that stands for the International Student Surgical Network of Brazil, a non-governmental, non-profit organization that believes and advocates for global surgery and represents medical students, young doctors, and also residents. And now, the InciSioN Brazil is promoting its first series of webinars. And for this very fourth and final webinar of this series, I have here the honor to introduce you very special guests, very amazing guests. So if we can put them on the screen. Yeah. So, okay, perfect then. So today with me, I have very amazing guests, as I was mentioning. So I'm going to introduce them to you as the host for this meeting. So for Dr. Alexis, she obtained her medical doctor from the University of Nebraska Medical Center, and it is a general surgery resident at the Medical College of Wisconsin. She has field experience in 5 different countries, and she's currently pursuing a master in public health in clinical effectiveness at Harvard School of Public Health. And as for Dr. Poe, he's a medical doctor, a Master of Public Health and Global Surgery Research Fellow at the Harvard Program in Global Surgery and Social Change. His research involves studying the delivery of surgery under universal healthcare systems and examining how national and subnational health indicators can inform health policy. So thank you, Alexis and Paul, just beforehand for having accepted our invitation. Incision Brazil really thank all of you for having accepted the invitation, and we are very excited for the webinar today. So any first words to our audience?
Thanks for having us.
Yeah, thank you. It's great to be here.
Absolutely. So, just to explain a little bit for the audience, okay? First, Alexis and Paul are going to do some presentations, some PowerPoint presentations, introducing a little bit more about the topic of our meeting, which is sharing experiences putting global surgery into practice. And then you can perhaps make some questions during the webinar. And at the end, we're going to have a round table, a little bit of discussion with them. Okay, so Alexis, if you would like to share your presentation first.
Sure.
Okay.
All right.
Okay,
okay.
Yes, just to tell you that we can hear you perfectly, see you perfectly, and also see your presentation. Everything's
Awesome.
just fine.
Well, it's so nice to be here tonight and to share a little bit of the experiences I've had in global surgery. And today, the topic will be focusing on global surgery in practice and how you align with the needs of your in-country partners. Just to give a brief background on my experience and how I got interested in global surgery. I started out becoming interested in global health when I spent 6 weeks studying medical Spanish in Costa Rica. And there I found that I had a passion for working with people from different parts of the world, promoting global health as a college student. And then in medical school, I ended up spending 6 weeks in Honduras interpreting in a clinic just to sort of improve my Spanish and see what it was like to work in a global health setting. And I also spent a few weeks in Jamaica throughout medical school as well. But what I was concerned about was I didn't know how global health and surgery really aligned and whether it was possible to do those two things together. And luckily, I found the program in global surgery and social change as a medical student. I took a year off. I spent that year working as an RA with the program in global surgery and social change, and I ended up living in Haiti for a year. And that's where a lot of my global health and global surgery experiences has come from. But I've also spent time in India, Peru, and Nepal throughout my residency. And now I'm back as a research fellow with the program in global surgery and social change. I've been so fortunate to come back and work in Haiti, but also get to work with a number of amazing practitioners and medical students and people from all over Brazil. So it's been a fantastic year and a half. So when you think about working with your in-country partners, the most experience that I have in global surgery comes from Haiti. And so I'll just give a brief background on the country itself and then talk about what I mean what it means to align with the in-country needs. So Haiti is a country in the Caribbean that shares a border with the Dominican Republic. It's part of the PAHO region of the WHO. It's what's called a low-income country, and it's home to 11 million people. There are about 532 women who die per 100,000 for maternal mortality. And then when you think about overall SAO providers, they're about 5.9 per 100,000 compared to the Lancet goal of 20 per 100,000. And in Haiti, only about 4% of the population has any sort of health insurance plan. And in addition, almost 56% of the population will face catastrophic expenditure when they try to receive surgical care. So in terms of the health indicators, it has some of the least favorable in the region, but there's a number of organizations around the country who are working to improve this. When you think about how the healthcare system is sort of arranged, there's first level hospitals, which provide primary care and are mostly located in cities. And then those are sort of run by the city director. There's second level hospitals that are, there's one in each of the 10 departments of Haiti, and those are run by a departmental director. And then there's tertiary level hospitals across the country, and those are the ones that I've spent the most time working in. And those are run by them, sort of organized by the Ministry of Health. When I think about where I've worked in Haiti and the experiences I've had and how I came to sort of know what the in-country needs were, as I mentioned, I spent a year as a medical student working alongside the general surgery residents at the Partners in Health Hospital in the center of the country. It was here that I really got to meet a lot of the Haitian providers for the first time and really see some of the challenges that patients and their providers face in a country without enough staff, space, and systems to provide surgical care. And then throughout residency, I've been working with, out of this relationship where a number of residents and providers are really interested in clinical research, I continued to work in Haiti throughout my residency to help individual researchers and surgeons sort of develop their projects and take them from an idea to a paper or a presentation. And so this is a picture of our group that's been working out of the South at Health Equity International for the last 5 or 6 years to build research capacity. And then when I came back to the program in global surgery and social change, there were still a number of clinicians who were very interested in research, but didn't necessarily have their resources to sort of pursue it on their own. And so that's when we started working together with the St. Damien's Hospital, which is the only pediatric surgery fellowship in the country. And we worked alongside the pediatric surgeons and pediatric fellows to help them with their research projects, which I'll discuss a little bit later. And I've also worked with surgeons more in the northern part of the country to help them develop their research. And then most recently, and perhaps the biggest need that in-country partners expressed, you've noticed the theme has been building up research capacity. There were 3 institutions in the capital city and who are leaders in the country who really wanted to focus on building a year-long research curriculum and focus on how to move research forward in the country of Haiti so that clinicians can guide practice by evidence-based medicine in the future. And so that's where the PGSS sort of came, my role in the PGSS came to partner with the needs of the country. And I was fortunate to come back as a fellow, and our current work for Team Haiti is really focused on research capacity itself to align with the needs of what has been expressed throughout my last 5 or 6 years working in the country. And so what's come out of these relationships is that currently in Haiti, there's several individual institutions that have all been striving for the same goal, which is to advance research in the country. But there's not a unified effort to train clinicians on how to do research or any sort of organized curriculum thus far that's available to a number of surgeons and anesthesiologists and obstetricians around the country. So working together with 5 partners. One is the only peer-reviewed surgical journal in the country. The other is a institution that works with the government to educate and train residents, clinicians all across the country. And the third is an individual organization that's been doing research training intermittently over the last 5 to 6 years. Those three institutions came together and said they had a shared vision and wanted to create a sustainable research curriculum for physicians in Haiti. And by doing so, they also wanted to partner with the World Health Organization and the Ministry of Health to make sure that this curriculum is something that can be eventually rolled out on a larger scale for the country. At the same time that those three institutions were coming together, the government put out a document on the importance of research and health, and they wanted to focus on 6 key domains, which aligned with what some of the projects that we've already been doing with the program in global surgery and social change and the 3 institutions I mentioned prior. So they wanted, the hope is to hold a national research meeting with a number of institutions across the country, including medical schools, government institutions, health information systems, and existing research pillars in the country to sort of come up with a plan to how to advance research forward. But this meeting has been on hold given the current COVID-19 pandemic. However, we have moved forward with the actual research curriculum itself. And so we've developed a concept note which outlines the project timeline over the next 12 months. And we have submitted this to become a partnering project with the WHO or PAHO in Haiti. And then we've actually developed the curriculum itself with our in-country partners. With the 3 institutions, we meet on a weekly basis and discuss. The first thing we talked about was what would be included in each part of our curriculum and what would cover in each module and how long it would last. And then we've broken it down into the very specific topics that will fit the Haitian context for research and how to do research within Haiti. And so we're currently in the process of finalizing the module content and getting ready to start the curriculum in January of 2021. And then when we think about how this curriculum is going to change clinical practice and improve surgical outcomes across the country, I can just provide a few quick examples of how it's already done so and what we've learned from the individual projects I've worked with clinicians on. One was looking at burns in Haiti. We know that burns cause about 180,000 deaths worldwide. Children are at a higher risk and mortality is much higher in LMICs like Haiti and Brazil, and that patients often face delays when seeking, reaching, and receiving care. But what one of the physicians wanted to study was how those delays and the use of pre-hospital treatments affected burn outcomes in Haiti, and especially children. And so she asked all the patients what they used to treat the burns before they arrived. And in Haiti, there's a wide variety of pre-hospital treatments that have been used, including toothpaste, animal excrement, indigo dye, and Vaseline. We found that a quarter of the patients that were in our study actually had undergone pre-hospital treatment of burns. About 50% of them used what was called traditional medicine, which can be any number of combinations of some of the things listed above, or there's a number of additional products as well. And then we found that the use of traditional medicine or pre-hospital treatment was associated with a higher infection rate, and this was statistically significant. So now our next steps are to how to educate both the community and our patients on what are the proper, not what are the proper, but what are the things you can put on a burn that will lower your risk of infection before you get to the hospital. In addition, working with the pediatric surgeons, as I mentioned, we've really focused on how to treat congenital anomalies in countries where you don't have access to TPN or some of the things that you would have in higher income countries. So we actually were able to write up an article on how to modify a surgical procedure for a congenital anomaly with the resources available in Haiti, and published that recently. So hopefully that will guide clinical change across Haiti and then potentially in other parts of the world as well. So that's a little bit about my experience in global surgery, and with a specific focus on the work that we've done in Haiti, really focusing on partnering with the clinicians who are in country and focusing on what their needs are. And then I'll hand it over to Paul, and I just wanted to say thank you again to InciSioN Brazil. It's great to be here, and we'll let Dr. Truche share his presentation as well.
Okay, thank you so much, Alexis. Now you're back on the StreamYard, and I can tell. Thank you for providing such a data and also sharing with us a little bit of your journey to actually address and apply global surgery into practice. So thank you so much again for the lecture. I hope that everybody enjoyed. And now we can add Paul on the screen. Alexis, I'll see you soon for the questions from the audience. Okay, thank you so much again. Let's put Paul on the screen. Hello, Paul. So let us put the PowerPoint presentation? Okay, perfect. Paul, we can see you, hear you, and see your PowerPoint presentation. In case there is any kind of problem during this transmission, I'm going to try to speak to you and say what needs to be done, okay?
Perfect. Sounds good. All right. So thank you everyone for having me tonight. And I work very closely with Dr. Bowder in a lot of our Brazil research. And I wanted to step back and take a little bit more of a 30,000 foot view, looking at how we adapt the global surgery work that we're involved in, and that many of you either are involved in now or will become involved in throughout your careers, and how we actually apply that to change at the ground level. And so I have no conflicts of interest. So I just wanted to start with kind of how we approach research typically is always with starting with this question. And then I think we don't have much of a problem of trying to answer the question through research, but when we get to the uptake stage, sometimes we struggle with who is going to uptake the information, or kind of how are we going to actually apply these practices, especially when it comes to surgical care into on-the-ground changes. And we know that the time that it takes for research to go from research findings to uptake by physicians, for example, takes 17 years. But what about uptake by governments, ministries of health, and other organizations or healthcare systems where you're trying to enact change or improve access to surgical care? That may take even longer and is fraught with many political obstacles. So the real question becomes, how do we translate the global surgery research that we do into practice, into something that changes care, into something that improves outcomes, into something that improves investment in the systems that we're working in, or a combination of all of those. So I think the first and kind of most important thing to understand is that global surgery is a little bit of a misnomer, because the research that we do in global surgery can be local research, it can be regional research, it can be national research, and it can be international or global multi-country studies. And each one of these plays a critical role in global surgery, and each one of these helps to design the very policies and clinical changes that we look to see on the ground. So the first kind of point of trying to figure out how best to have your actual research translate into on-the-ground change is to figure out the scope of your research and realize that you don't have to take a local research project, which is very important, especially in a local context. And you don't have to try and apply that globally necessarily, or apply that nationally. You can, have your research whose scope is to improve local access to surgery or local outcomes. And I'll give some examples of some work that we've done with this, and how, and how determining a scope of your research and accepting the scope of your research can really help you understand what that will inform in terms of on-the-ground change. The second probably really critical portion is to recognize who your audience is for your research. So if you want your global surgery research to enact change in some way, you need to figure out who are going to be the people who are going to read your study, and more important, who are those that can take action based on the findings of your study. So that may be clinicians. You may be doing a single center or multi-center clinical trial, trying to see if one type of surgery is better than another, or one medication given preoperatively is better than another. Something that you want clinicians to read and uptake into their practice that will improve the surgical outcomes and the care of surgical patients. Your audience may be hospitals, it may be entire healthcare systems, it may be SUS, it may be smaller local regional hospitals, it may be a single private hospital. But if that's the case, you need to frame your audience, frame your findings a little bit differently for your audience. And then lastly, your audience could be a government. It could be a ministry of health. It could be a local government. It could be a regional government, or it could be a national government. And your approach to influencing policy change at that level is also going to be different and require you to contextualize your findings a little bit different than if you were trying to reach clinicians directly. Next is determining what the action steps are for your findings. So I think this is where we as a global surgery community probably fall short the most. We do a lot of research and we have a lot of very interesting findings, and we show a lot of burden. We show health disparities. We've done this in Brazil and across many countries, but we don't always clearly outline for our audience what the next step is, what they need to actually do. And I think that is the most critical step to ensuring that whatever the research that we are performing in global surgery is actually going to lead to some sort of on-the-ground change. And that change could be something like more research. It could show that more data needs to be collected, or better data needs to be collected in order to answer the questions or have more definitive action steps. And if that's the case, that's a perfectly acceptable action step. It may be increasing investment. You may be trying to argue that you think that there needs to be more money invested in hospital systems to provide a certain type of surgical care, or there needs to be more infrastructure, or something that is going to require increased financial investment or support in a surgical system. You may advocate for a change of practice, which could be anything from on-the-ground clinicians saying you should use drug X instead of drug Y, all the way to a change in how the government may actually oversee their policies or instruct physicians to treat certain conditions in a certain way. And that sort of leads into the fourth and probably most broad and difficult action step to suggest, and that's enactment of a new policy. So when you believe that your work and your findings warrant a complete change in how the government, or even potentially a local or regional health system, is delivering care, and you are advocating for a policy change, it's very important to start to outline what exactly that policy might be. And I'll talk about some ways that that these kind of policies have taken effect in the global surgery realm shortly. So I wanted to just start with an example of some local scope research that can lead to practice changes and also lead to more regional and potentially even global research. So this is some work that we've recently published, led by Dr. Fabio Botello. It's a colleague from mine from Minas Gerais. And we worked on a study looking at how primary surveys of trauma patients were performed in a Brazilian trauma center. And the ultimate goal of this was to improve the assessment of children during the initial assessment on trauma, with the ultimate goal of improving their outcomes. So this is the kind of study that is applicable at a local level, but we still consider global surgery research, because the global, as I said, is a misnomer. So this may improve care or spur more training to be done at his specific hospital, but also importantly, it acts as a model potentially for studies to be done at other institutions in Brazil or even internationally. So these kind of studies, while perhaps not global in the scope of the project as a whole, still can have a global impact, acting as a model for other physicians, other surgeons who want to start to understand and research maybe how their primary surveys are being performed in a trauma setting and how they may be able to improve care. So just to kind of think about how, from the conceptual framework that I laid out, you have a study there that is trying to influence the way that clinicians and hospitals are going to provide care. And the results are directly applicable to them, who's your audience, advocating for a change in practice, increasing the amount of training done by pediatric surgeons, and introducing some things like a checklist and other interventions that can help guide the trauma assessment, with the ultimate goal of improving outcomes, and with an overarching possibility of this being a model for other institutions. Now, some other work that's done by a colleague of mine in Amazonas, Dr. Jose Emerson. So he's done a regional approach to research in global surgery in Brazil, assessing 20 hospitals across the Amazonas region to understand the infrastructure and the workforce and the surgical volume that is present, in order to hopefully inform future research and spur the state government to invest and introduce new policies to improve surgical triage for patients in rural areas of Amazonas. This was an abstract that he presented at the Academic Surgical Congress, and he also has a full manuscript of this paper that's currently under review. And this is the kind of research that takes a regional approach to global surgery, and the ultimate change that it wants to enact kind of is very cross-cutting, in that it's prompting further research, trying to introduce local and regional policy, and also advocating for funding change from the government, from the SUS system, in order to potentially improve surgical care and access to surgical care across Amazonas. And again, studies like these can be used in the future as models for assessing surgical capacity in other areas. This study in particular used the surgical assessment tool, which is a facility level tool to understand how surgery is delivered and what the infrastructure and workforce are at any given facility with respect to surgical care. So you have a study the ultimate readership is aimed at government or other organizations that are delivering healthcare, advocating for more research, increased investment, and enactment of new policies. And then the question really becomes, what can the government do in response to this at a regional level or potentially at a national level in order to act on the findings? And that can take multiple approaches. Many of you may have heard of national surgical, obstetric, and anesthesia plans, which have been adopted in about 7 to 8 countries at this point, which are sort of standalone plans for how to deliver surgical, anesthesia, and obstetric care nationally, which includes financing, includes training workforce, potentially includes building hospitals and increasing infrastructures. And as you know, in Brazil, you have a very strong national health plan through the SUS system that is already delivering healthcare. So the question is there a need for a standalone surgical plan, or is it better to advocate for incorporating surgical care and reducing disparities in access to surgical care within the national health plan, which I believe is probably the more optimal strategy rather than a standalone plan. But I do want to highlight that other countries, Pakistan in particular, have focused on a regional national surgical plan, an RSOP, where they essentially did separate regional surgical plans, which would be, if done in Brazil, would be similar to having each state have its own surgical plan, or NSOP, but from a state level, in order to take into the local context of each state and where the gaps may be for that individual state, and where there may be financial or funding lack of funding, workforce disparities in workforce within state to state, and how to address those. So these are how, from a national level or from even a regional level, there have been some large policy changes in surgical care globally, and where probably the next level of surgical policy from a national and subnational standpoint will be for Brazil and other countries that have existing universal health coverage schemes. And so I wanted to kind of focus on these next 2 studies. This was a study from back in 2015, which was a national study of Brazil modeling all 6 of the Lancet global surgery indicators. And studies like these really are a national exercise with a global focus that's trying to allow the data to be available to compare countries, as well as some subnational focus in that they did compare the different regions within Brazil with respect to the surgical indicators, although it doesn't get into state to state or even more granular than that. And alongside, for example, a pediatric specifics study that was done by Dr. Bisocci and Henry Rice, looking specifically at pediatric surgical care, you have another research with a national focus looking at disparities in access to children's surgical care across Brazil that has local and regional implications with respect to how local healthcare, local government healthcare may be able to improve and reduce disparities in access to surgical care for children. So again, this is an example of a study that's aimed at the government trying to action or a new policy change with the ultimate goal of reducing disparities in access to surgical care for children, both nationally and regionally. And I wanted to leave off on a study that we also published recently last October, which was a global study that we performed in Brazil, or a national study that we performed in Brazil, looking at the bellwether procedures for trying to understand differences in all-cause perioperative mortality across Brazilian states, and whether the bellwether procedures, which consist of open and laparotomy, cesarean section, and open fracture management, would be a good proxy in Brazil. And this ultimately, our goal of this was to have a global focus to say, if we can see a relationship in Brazil between the bellwether procedures and perioperative mortality, could other countries then utilize a similar approach to understanding subnational variation or variation between different regions within a country in perioperative mortality? And we did find that for trauma laparotomy, there was actually a fairly good correlation between higher perioperative mortality overall and higher perioperative mortality for trauma laparotomies or for open laparotomies. And so the proposal is that this could be applicable to other countries. So again, this is a national study for Brazil, but with a global idea that we want to be able to model this for other countries to potentially use. So that I wanted to just leave you guys with this kind of framework for application and adaptation of global surgery research to policy, that global really means local, regional, national, or sometimes global. So your research that may be done to improve surgical care at a local institution would still be considered global surgery and can still have just as much of an impact as some of these national studies or even multi-country studies when it comes to actioning change on the ground to improve surgical care. And it's very important to identify your audience and then identify what the action steps for your audience are in order to actually adapt your research findings into potential policy changes. So it really is guided ultimately by how will your action steps be implemented by your audience. And that's it.
Okay, let me just put Alexis back too. So, Paul, regarding your presentation, thank you so much. For me, at least, it was very clear because you actually addressed the main points for us to advocate for global surgery. And even I think this is going to be very useful actually for InciSioN Brazil and even for other national working groups inside InciSioN. So thank you so much for your talk. I really enjoyed reading, and I actually wanted to congratulate both you and Alexis because we have very good questions from the audience. So for this point on, we're going to highlight the questions. I'm going to read it out for you, and then we can discuss a little bit. And don't worry, it doesn't need to be short. Try to talk about everything. Okay, so
Great.
let's start with a question. So we have a question here from Maria Eduarda Mesquita. Now that's my Portuguese accent. So how can I convince doctors to apply the evidence found in research? And then she continues here on the other comment saying that on her teaching hospital, we don't even practice the safe surgery checklist because the doctors don't accept it. So how can she convince doctors to apply the evidence? What would you say to her?
Would you like to go first, Alexis, or would you like me to answer?
Alexis, your microphone. I was just
I
going
think
to
as
tell you.
medical students, you're in a tough position to convince doctors to do just about anything. And the most you can do is just share the literature on what you have. I'll let Paul speak to that too. And then in the end, remember what you want to do when you are finally in that position to follow the safe surgery checklist. But I put as you can see, there's a lot of variation in its acceptance globally. I put a journal out there to your host so you guys could read that one. It was just published in January, so you can take a look at that. And then Paul, go ahead.
Yeah, that's a very tough question, and we know that it takes 17 years for physicians from time a study comes out for it to be fully adopted by everyone, and that's with very clear-cut evidence. There has been some work looking at it's in a field called implementation science, which is really trying to scientifically understand how things are, new policies are uptaken or new clinical guidelines are uptaken by physicians. And what has kind of become clear is that the key factor to implementing something like the safe surgical checklist is really culture. It comes down to having a surgical culture that accepts it. And unfortunately, that can take time to develop, and it may not be possible as an individual medical student to affect one individual surgeon or several surgeons specifically to start utilizing the checklist. But from a facility level, from a cultural level, as more physicians who understand what the benefits could be, and nursing is included, and perioperative services is included, and anesthesia is included, and the kind of teamwork model is more, it becomes very culturally appropriate for the nurse to point out if there's a breach in something in the operating room, breach in sterilization. It becomes the medical student feels comfortable speaking up that the safe checklist wasn't done. As that culture develops, which can be very hard to do and take time, I think you will start to see more adoption of practices like that.
Indeed, that's something related to the culture because at least here in Brazil, at least in my medical school, some students are even afraid of disagreeing with the staff members and disagreeing even with the the residents. So how to propose change if we not feel very welcomed on the environment. That's actually very true. Thank you for you both. And now for the next question, let's swap the order. Now Paul is going to start and then Alexis goes second. So we have a question here from Italo, and he says, are you aware of any other countries that were successful in implementing global surgery policies?
That's a great question. So again, this depends on what the scope of your policy that you're looking at. So I would argue that almost any country in where there's surgical research going on that's improving the clinical care within that hospital or within a small healthcare system, those policies are enacting change, and that is the majority of countries. On a larger level, things like national surgical, obstetric, and anesthesia plans, which have been adopted in a number of countries, it again depends on how you define successful implementation. So these plans have been written, drafted, and approved by the government, by ministries of health, and are currently in the implementation phase. So it's a little bit hard to say what will be the successful parts within those plans and what will not be those successful parts within those plans. But that will be hopefully to come. I would say that as of now, there has not been great implementation of the national surgical, obstetric, and anesthesia plans, and funding has been probably the biggest limitation. From a universal health coverage perspective, or countries in Latin America, to date, none have undertaken an ENSO plan or something similar to by integrating them into their existing national health plans. And that's probably where the next step in the future for global surgery from a national policy level will be for Brazil and other Latin American countries in the future.
Okay, thank you, Paul. Alexis, any compliments about polls, and even you have experience in 5 different countries on the field. So what would you like to share with us?
Yeah, I think that's a pretty broad question. Global surgery policies can mean so many different things. I'd say from a research capacity building, Rwanda has done it really well, and they've partnered with Partners in Health. So there's a good example there of how to build capacity over 5 years from a research standpoint. And then a number of the other countries that I've worked in, as Paul mentioned, so Nepal is just in the very beginning stages of developing an ENSO, and implementation has been one of the biggest challenges. And I think you'll find in global surgery again and again, it all comes down to funding. And without it, it's very hard to implement things and to implement them in a sustainable manner, which is the other issue. You'll hear a lot about different projects, but whether or not those projects can actually sustain themselves for more than 1 or 2 years is another question. And so I think Rwanda is probably the best from a research capacity standpoint. In terms of other global surgery policies, I would say it's only been 5 years, so it's hard to really know what's been sustainably and well implemented thus far across the rest of the world.
Okay, thank you so much, Alexis. Now let's move forward to another question, and I'm really looking forward to hear both of you speaking about that. So the question is now from Mateus, or in English, Matthew. So in your judgment, what Brazil can learn and apply from your experiences in our unified healthcare system? So that's actually very interesting, because at least global surgery here in Brazil is still urgent, is something that not many professionals know. So what we can learn from those experiences?
And I think it's my turn to start, but I think some of the work that Paul and I and a number of other members of InciSioN Brazil have been trying to, I think the regional care in Brazil is quite varied, and one of the things that could be useful in Brazil under the universal healthcare system is regional ENSO. So like the Amazonas, for example, is an area where care and access to care is one of the larger challenges when compared to like Sao Paulo or the South, where you have better access. So that's one, looking at ENSOPs and whether those would be regionally useful in Brazil. And then I think that was the first comment that came to mind. I'll hand it over to Paul and see what else he has to add.
Yeah, I think that's a phenomenal question. And that's kind of probably my biggest personal interest, is in really studying how we can improve surgical care within systems like SUS. So you have many countries like Brazil, and at this point have adopted universal health coverage systems, which the aim is ultimately to provide care for all that is without risk of financial catastrophe or impoverishing expenditure for patients, which on paper the Brazilian SUS system is supposed to provide. However, surgical care and really what I would call complex interventional healthcare, which is really any healthcare that requires a point of care intervention, but also requires pretty significant pre and post care of patients, requires a lot of different infrastructure, specialist workforce, etc., than does something like providing vaccines or providing primary care or things of that nature. And so I think many health systems thus far have especially countries like Brazil, Colombia, other Latin American countries, rely on the private healthcare sector to fill in a lot of these gaps, especially for things like surgical care, and trying to understand how the public sector, how SUS can actually, where the gaps are is one thing, which I think is not always all that clear so far, that we are doing research in, and where and what they need to invest in. What kind of specialists do they need? How can they encourage specialists to work for SUS or provide more surgical volume, for example, for the SUS system, rather than working primarily or partially in the private sector, and then maybe less in the public sector. So I think there's a very complex interplay between providing universal health coverage in a system like SUS and understanding and providing complex care like surgical care within SUS that would be freestanding and not overly rely on the private healthcare sector, and also be financially viable, as well as protect patients from having to pay too much. So I think that our experiences so far have highlighted that, one, we really need to work to figure out where the disparities are, what branches, I don't want to say branches, but what parts of surgery or types of surgical care are really lacking, and show what the cost is of this lack of access to surgical care. If a patient cannot get an operation under the SUS system because the hospitals are too far away, or there are no surgeons available, or the wait list is too long, what is that cost of the patient waiting and having a more complex case, or being forced to find healthcare in a private hospital and undergo surgery there and pay the money? Things like that are kind of where I think we're going to need to go next, with the ultimate goal of designing some strategies, some policies that would build into SUS, but that would be specifically designed for that complex interventional healthcare component that I think is kind of understood and not financed heavily enough.
And this is actually something very interesting that both of you commented, because on the first webinar of this series from InciSioN Brazil, we have invited Professor Nivaldo, who is someone that you both know as well.
Mm-hmm.
And it was very interesting because on his webinar, he was basically introducing what was global surgery to the main audience. And when he showed to us the health indicators that Lancet put on the very first article in 2015, and we saw the health indicators, we were like, okay, this is matching accord with Lancet Commission. Why can't we see these actually being executed here in Brazil? So actually looking for the branches to the gaps, like you've mentioned, Bo, I think this is going to be very challenging because the health indicators are really not matching. And Alexis, before I go to the next question from our audience, I just wanted to ask you actually, because you could experience 5 different healthcare systems. You were able to work in 5 countries. So I was wondering, what were the main differences that you've noticed when you were working that actually strengthened or weakened the possibility to implement global surgery? I was really wondering that. So could you comment on that?
It very much depends on the country. So Brazil has universal healthcare, but Haiti does not. As I mentioned, only 4% of the people in the country have access or any sort of coverage for their health. And then I think not so much what's different, but what's always the same. And access to care is one of the biggest challenges across all the countries I visited. So whether you have insurance or not, if you can't, I think the barriers to care are one of the most limiting things, and they vary by country. So in Nepal, it may be that it's just a mother and the spouse is working somewhere else, so they can't take their kid to the hospital because they're just a single parent. And in Haiti, you make less than $1 a day, so you don't want to go get surgery because you don't want to stop working. And then, but what's consistent across all is that the barriers to care, especially access, are incredibly challenging. I think when I was in Nepal, I decided I'd rather die of peritonitis than travel like 6 hours in a Jeep on a bumpy road. And those are the decisions. I mean, I was in a car. Most patients walk or have to be carried in Nepal and Haiti. And India is I think a country that I've visited, but I can't really speak to their healthcare system without spending a lot of time there. But the levels of what is covered by insurance is one of the biggest barriers in whether insurance exists in a country. And then I think the access to care and how that's managed. I mean, I think it was fascinating in Brazil to see like there are gaps and there are disparities, but it seems to be like in a little bit of a better place than some of the other places that I've worked. And then also just specialization of care. So there's big differences in Brazil. You have pediatric surgeons. In Nepal, there's no pediatric surgery fellowship to my knowledge. In Haiti, there's only one. So there's 6 pediatric surgeons for 3 million children. Whereas in Brazil, I think the numbers are a little bit different. So there's, in terms of providers, access and insurance, those vary from country to country.
Okay, thank you so much for the insight. I was really curious. I'm glad that you have clarified a little bit in my mind. And now we're going back to the audience for the next question. And actually, Alexis, you have anticipated a little bit about the question on your answer, so that was quite perfect. So Angela asked, what were the main challenges that you faced in your experience to advocate for global surgery?
Yeah, I'd repeat the barriers to care. They vary by country, but I think they're incredibly important. And then access to care. If someone could figure out how to make travel less than 2 hours and reduce the delays, I think we'd have better outcomes worldwide. But if they do that, they might get a Nobel Prize because it's something people ponder about over beers and dinners in countries like Haiti, Nepal, and Brazil all the time.
Okay, what about you, Paul?
Yeah, I mean, at least for me, some of the biggest challenges are really understanding the nuances of different countries and and the way that surgical care is delivered. And I think that many countries struggle to even understand exactly how surgical care is, surgeons within their own countries struggle to understand exactly how surgical care is delivered. And it's complex in the United States as well. I can't even claim to completely understand, especially in all states and all regions, how surgical care is delivered. So I think finding strong local partners who can really start to delve into understanding those nuances is a challenge, and it's very, very rewarding once you develop those relationships and you develop those connections. And I think it spurs some very rewarding research. But it's very difficult to start those relationships and to find people that understand those nuances and can sort of guide research to address and discover the disparities among those nuances.
Okay, thank you very much for both of you for the answer. And now let's move forward to the next question. Okay, so Vivian asked both of you, Pro and Alexis, what do you believe were the most positive aspects of your experience, of such experiences, in special to Paul about Brazil? Can you see any differences for the community, for healthcare professionals? Okay, so Paul, since Vivian addressed you, so can we start with you then? And then we'll go back to Alexis.
I think the most positive experience, I think global surgery is really a phenomenal field to be getting involved in, and it's really kind of at its infancy as a formal, research-driven, evidence-based field to really drill down and understand how surgical care is delivered in different countries and how different countries can inform each other. I think Brazil is an absolutely wonderful country, and I think that it's positioned uniquely in that you have a strong national healthcare system that is providing good care for the majority of the population. There are gaps, there are disparities, there are financial barriers, and there are problems, as there are in all countries. But you have an enormous wealth of data that's been kind of developed through the SUS system as well as through ANS. Even the private system has some data. And it's really the kind of a country where we can start to understand those subnational disparities, and what was kind of alluded to before of the Lancet Global Surgery indicators. They're very broad, and they're designed for an entire country as one to have a snapshot of how surgical care is delivered. But surgical care is much more complex, and the care that's provided in Sao Paulo, very different from the care that's provided in Amazonas, and what the specific disparities in access may be. And those are the kind of things that are not captured in national health indicators like the Lancet Commission on Global Surgery advocates for. And Brazil is a country where we can really start to delve into real state level, even municipal level data to understand how surgical care is delivered. And I think that the surgeons, obstetricians, anesthesiologists, providers in Brazil are interested in this as well. There's a real interest, and that's seen evident by the number of students that are also interested in it. And so it's just been a wonderful experience to be able to work with Brazilians and with the collaborators and the connections that PGSS has been able to have, and that I've been able to have, to really delve into these issues. And they will be able to inform other countries that want to understand how care is delivered on a subnational level, but don't even have the data yet to understand what to collect. And I think that's where global surgery research in Brazil can inform many other middle-income countries, upper and lower, into where they should start collecting data, where they need to start understanding the disparities, and to go from there. Great question.
Okay. Alexis?
And then I'd echo that global surgery is really a great thing to be involved with. And I found that throughout my travels, I often learn more from my partners than I think I have to offer. And it makes me a better clinician. So I think being involved as a med student is super useful, and you can observe things. And while you may not be able to voice how you would change it in your own clinical practice as a student, you can carry that with you as you move forward to and attending. And I agree with Paul that Brazil is really in a unique sort of place in global surgery because it does have pretty broad coverage when you compare to some other countries around the world where global surgery is sort of picking up momentum. But yeah, I'd say that the best thing that you can take away is the people that you meet around the world. I mean, Fabio is amazing, and all the Brazilian collaborators that I've worked with have been phenomenal. And sometimes I call people from other countries when I'm on call and say, what would you do with this? Because I've not seen this before. So the relationships are really long-lasting and incredible.
Absolutely. And I'm going now, unfortunately, sadly, to the very first, to the final question from the audience, but the audience was just striking. So since InciSioN is about as well medical students, Lucas' question is actually very interesting. So, dear Paul and Alexis, what do you think can be an interesting way to achieve more engagement for the youth regarding meaningful student involvement and youth engagement in global surgery? Oh, I really like the question. Okay, so who wants to jump in?
Is that me first or you first, Alexis? I don't remember.
That's one. I want you to.
I can go first if you want.
Yeah, go ahead.
Okay, I think that's a really, really good question. And I think that the biggest barrier for students interested in getting involved in global surgery is lack of mentorship. Being able to find a mentor, somebody who has some experience and can really teach you and has your interests in mind, is difficult. And I think as students, as you are in a generation of students interested in surgery and global surgery, that's probably the most difficult generation because there are not that many physicians and surgeons that are mentors, 10 years ahead of you who can teach you and who paves the path. So you are the ones who really are going to have to pave your way into global surgery and through the research. Some of the best experience that I've had is working with students and watching them go from interest. Students like Isabella Faria and Joao Neto, they were also InciSioN members. And watching them go from students interested to now leading research projects and coming up with questions and designing research projects that we're currently implementing. And that transition to me is, and seeing students through that transition is the most rewarding factor. So I unfortunately cannot personally mentor every single student, but as more of you and others become more skilled in global surgery and have more experience, the abilities for mentorship. I see the Gender Equity Initiative in Global Surgery has a mentorship program, which it's a fantastic mentorship program, and I highly recommend getting involved in that group if you're interested. Finding those mentorship opportunities is the biggest thing you can do as a student, finding a mentor who is going to be able to kind of guide you and provide you with some experience. It's difficult, I won't lie, but it's probably the most important part. And being involved in organizations like InciSioN is really the pathway there too.
We're here for that. We're here for that.
Yeah, I'd say the other thing that goes with finding a mentor is the worst anyone's ever going to say to you is no. So don't be afraid to ask for an opportunity, right? So if you're like, oh, that surgeon does global surgery, but I'm too scared because it's Dr. Navaldo and he's like the famous global surgeon and like the best plastic surgeon in Sao Paulo, well, just ask him, because the worst he's going to say is no, and then you just move on and try to find somebody else. But what you'll often find is people usually say yes, and then your mentorship you can find a mentor that way. In terms of other organizations, like Paul mentioned, I think the Global Initiative for Children's Surgery is a great organization that's really focused on involving LMIC partners from the beginning, and they do a lot of amazing work and have a number of different committees around the world. There's the G4 Alliance. InciSioN, I think, is really one of the most unique organizations that I've seen come out of global surgery. And as Paul said, you guys are sort of leading the way in the connecting across multiple platforms that some of the older global surgeons have not done in the past. So staying involved in InciSioN, not being afraid to ask for opportunities, because it's not going to hurt you if someone says no, and then looking to find the other sort of specialty-based global surgery organizations. So there's one for anesthesia, the WFSA, there's one for orthopedics, there's now neurosurgery one. And just don't think that because you want to do some certain specialty, you can't do global surgery. I guarantee someone's trying it somewhere, and you'll find them.
Yeah, I want to add 2 points onto that. The first being that sometimes you find mentors as they are growing. I can tell you from my personal experience, my very first global surgery mentor was Dr. Gregory Peck, who is at Rutgers and has done a lot of research in Colombia. And when I started doing global surgery research, that was the same time that he started global surgery research. And although he was an attending trauma surgeon at the time, he did not have very much more experience than I did at the time. And we learned together and we worked together, and he mentored me. And many times you get as much mentoring from your mentee as you do from your mentor. It's a really bi-directional relationship. So look for people that, you can look for people that may not have as much experience in global surgery, but if they have an interest and they are ahead of you in their career, you can build pretty strong relationships that way. And I would say that the second is that it doesn't always don't get too tied up in the word global surgery. There's a lot of public health research that you can get involved in as a student, even a student interested in surgery. And you can do research in public health that may not be exactly surgical care, but will teach you the methods and be able to have you develop mentorship with doing research and doing policy change, whatever your interest might be, and give you those skills that you can then transition to using for global surgery research. So it may be a public health in surgery. It may be a surgeon doing surgical research in Brazil who doesn't see their research as global surgery related, but it's surgery research that you can learn from and then apply in a global setting at some point in your career. So don't only focus on mentors for global surgery, focus on healthcare researchers, surgical researchers, public health researchers, and those methods will always be interchangeable with the methods that we use to evaluate surgical systems.
Okay, thank you very much. I'm really sad to say goodbye, to be honest, because I was really enjoying this webinar. But we have no further questions from the audience. But really, Alexis, the webinar was fantastic. I'm really honored to be the host for today's webinar. I learned a lot from you too, and I believe that the audience as well. So thank you very much for the opportunity for spending your time here with InciSioN Brazil. And I hope that we as InciSioN Brazil can collaborate more with you and also with the PGSS. So thank you very much once again. And for those who are still watching us, don't go check our YouTube channel to see the previous webinars because they were also great. And then you can learn more about global surgery, and stay tuned with InciSioN Brazil's social media, because we're going to recruit new members soon. So don't miss the opportunity. So Alexis and Paul, very well. Goodbye. Thank you very much once again. Okay, have a
Thank you so much.
good
Thank
night
you.
in that. This is still 1 hour, so
Good night.